Assalamu alaikum. Thank you, Mr. Chairman. My name is Bachar Afandi. I'm an endocrine consultant at Tawam Hospital in Al Ain, UAE. I'm very glad to present in this meeting. And I will be focusing in my presentation on the population that chooses not to fast during Ramadan. So this is the outline of my presentation. I'll be talking very briefly about diabetes and Ramadan risk calculation. I will review the rates of high-risk populations in different settings. Then I will review the analysis of the non-fasting population, and I will talk about potential causes and solutions, and then I will go to the conclusions. Now, the 2022 diabetes and Ramadan risk calculation, as you all know by now, has 4 different factors that addresses 45 elements. And when you add them up, and this is the template from our hospital in Sahha, Tawam Hospital, when you add them up, you will get a final score and you will get a risk level. And with the risk level, you will decide, you will see the recommendations, you will see the medical recommendations and also religious recommendations. And this is by now is well established and known to all of you. Now, high-risk populations actually, we did not know for a long time what is the rate of high-risk populations in different settings. Now, this is a new study from the Imperial College in Al Ain by our colleague, Dr. Muhammad Sulaiman, shows that the high-risk population is about 21%. Not published, the data is not published yet. Same in Al Ain city, also in the ambulatory health services. Just now also, we have a similar results that the high-risk population in Al Ain AHS, a primary care setting, is also exactly 21%. Previously, a few years ago, we had a study in Tawam Hospital, and we showed that our high-risk population is about 28%. And this is not surprising that our rate is higher because, you know, we are a tertiary care center. Most of these patients actually, the high-risk population, most of them, 78% actually fasted against medical advice, and they had increased risk of all kinds of famous complications during their fasting. Now, in addition to the high risk and low and moderate risk, we had this group of patients, 9% of our patients actually did not observe fasting. They decided not to fast. And this is the population I'm going to focus here in our presentation. So we're going to review the non-fasting groups. And as you could, imagine there is a scarcity of data on this population. We're not sure about the proportion of patients that do not fast. We're not sure about features of these patients. We don't know the comorbidities and what are the potential causes of their non-fasting. So it was not addressed previously in research. It was not addressed previously in presentations like in this meeting. So that was the goal, the main goal of this presentation is to review the non-fasting population from different studies. We had over the past 2 years, we had many surveys to many providers in many countries, and that was, that extended from 2020 to 2022, and that was observational retrospective analysis of the data we attained there. And the objectives were to evaluate the features of the non-fasting population, and there are many factors. I'm sure I would not be able to cover all of them. To talk about gender, type of diabetes, smoking, treatment protocols, comorbidities, and of course, to assess the rate of these patients, what is the percentage of patients that do not fast, and also to compare with the total population. We had a total of 14,910 patients in the total population. Out of that, there was a non-fasting population of 2,680. And you could see here that the total population by country, you could see most of the patients were from Saudi Arabia, Pakistan, Algeria, and so on. And this is the total population. The non-fasting population was mostly, you could see Algeria, Morocco, Turkey, and so on. And that was 2,600. Globally, the rate of non-fasting was about 18%, with a very wide range from 1% in Malaysia to 56% in Turkey. And then you have Morocco and Iraq and so on, but very wide range of rate of non-fasting. 52% of the total population was female patients, but in the non-fasting group, it was about 55%. Age in the total population, we had about 19% more than 65-year-old, but in the non-fasting population, that was higher, up to 28% in that population. The duration of diabetes was very important, was 10 years in the total population, but that was more than 12 years in the non-fasting population. Type 1 diabetes was about 15% in the total population, but patients with type 1 diabetes were about 25% in the non-fasting population. Mean BMI was almost similar in the in both groups at about 26 to 27. A1C, the mean A1C in the total population was about 8.4, indicating a poor control of our patients. And when you think about the percentage of patients that had A1C of more than 9, it was about 32% in the total population. That was even worse for the non-fasting population. The mean A1C was about 8.8, and more than 45% of the patients had an A1C of more than 9. Now, when you think about comorbidities and diabetes complications, all types of diabetes complications and comorbidities were higher in the group that was non-fasting. All of them, take my word for that. I'm talking about from hypertension to hyperlipidemia to diabetic retinopathy and so on. All of them were higher, and I will review that a little later. The type of treatment was interesting, and in the total population, we had more than 43% of the patients on insulin. We had 80% of them on metformin. SUs and DPP-4 inhibitors were very commonly used in the population. 19% were on SGL2, and GLP-1 was used in 2.9%. In the non-fasting population, we had a lot more insulin use that went up to 63%. Very surprising to me, actually, that this population of non-fasting group was on less. I mean, we're assuming that this is a higher, very higher risk population. They were on less SGL2 inhibitors and also on less GLP agonists. In summary, and my discussion here, you could see that you could imagine that the predisposing factors for the non-fasting population, it's characterized by using insulin more commonly. Patients are type 1 more commonly, female gender, older age, duration of diabetes, longer one, A1C of more than 9 more common in the non-fasting population, systolic blood pressure almost similar. However, systolic blood pressure of more than 150 was about 16.5% in the non-fasting group and 13% in the total population. Smoking was also a factor, 7.5% in the non-fasting, and in the total population was 6.5%. Additionally, diabetic complications All of them were, as I mentioned earlier, higher in the non-fasting group: retinopathy, neuropathy, CKD, microvascular, macrovascular complications. All of them were higher in the non-fasting group. Diabetic foot was more common also in the non-fasting group. What could be the causes for non-fasting during Ramadan? I'm not sure. I mean, this is a new area, and we have to explore that. It could be actually compliance with the advice. It could be medical advice that he was told by a provider here or there from any specialty that you should not fast. It could be, I mean, a religious advice, not necessarily a medical advice. It could be the media influence. Do not fast if you have diabetes. We hear a lot about that. And it could be cultural values that you're not supposed to break your fast. You have to fast, whatever your condition is, and that probably, I mean, might explain the variances. I will talk about that, and you will have also a possibility that lack of medical knowledge or lack of medical advice. So patients are not getting advice at all, and that might affect their decisions to fast or not to fast. And very important, and that is addressed in the risk calculator, is bad experiences with fasting. So patients do not seek any advice now, and they just stop fasting, and they don't observe fasting anymore. Causes of the variances between different locations, geographical locations, could be cultural, could be that we don't have adequate guidelines. It could very possibly relate to the provider expertise. So, I mean, it depends what do you know about evaluating these patients and evaluating their risk. It could be that you don't have enough information about that patient. You don't have, so I might decide differently than you because you don't have enough information, or I don't have enough information. Very important, the service setting, like I showed you in Dawam Hospital, the higher risk groups are more than the higher risk groups in the primary care setting in the AHS or Imperial College. Again, poor communications between providers, among providers, very important. That might affect and cause different, evaluations. Poor educations for physicians and for patients also, and competing perceptions and different goals and so on. All of these might affect the overall populations that are not observing fasting after, hearing all kinds of different, sometimes conflicting advices. Solutions are many. I thought about these solutions. We need to improve our knowledge and all providers' knowledge. We have to be using the guidelines that are available. We have to unify our stratification protocols. We need to improve our documentations in the charts to be able to evaluate patients next year and to know what happened last year. Probably patients, score now is not going to be the same next year. So we have to, keep documenting and addressing the needs for certain patients. We have to refer patients always to diabetes education, which is the cornerstone in the care of diabetes, especially for Ramadan fasting and evaluation. And again, improving as I said, documentation, but also communications between providers and between providers and their patients also. In conclusions, I would say that many factors and comorbidities influence patients and physicians' decisions when planning Ramadan fasting. 20 to 60% of patients with diabetes are actually classified as high risk. We have a new study now coming from Sudan. I think their high risk population is more than 65%, I think. So you could imagine that different settings will give you different rates of high and moderate and low risk patients. Globally, as I showed you, you have 18% with a huge wide range between 1 and 56 of patients do not observe fasting. And very important that the new IDF-DAR risk assessment tool can actually help physicians in classifying patients during Ramadan and show your patient what's your risk stratification and where you are, and you could take it from there in order to advise them what to do. And that was my last slide. Thank you very much. Assalamu alaikum.